and then you can get some credit. Okay, thank you. So send your UW email address to 833-394-7078. You'll receive a response stating your number's been updated. And then after registration, you'll just text this 10085 to the number and get your CME credit. For anyone else who's attending, your attendance is going to be recorded by Sammy and also through Zoom Analytics. So please make sure that you're displaying your full name. And Sammy can reach out to you after in the chat or after for any additional information to track the CME for you. Okay, so for today, we don't have a formal case presentation. So if there's any questions, bring them forth. And we really are going to have a rich presentation about cognition primary care. So plenty to talk about. Email to Sammy if you do have a case to bring forward, though, please. No cases too simple. We'd love cases that have been presented before with updates. Really bring anything forward. We can all learn together with cases. There's a whole host of other wonderful UW Project ECHO programming in geriatrics, in traumatic brain injury, behavioral health, psychiatry and addiction, and telebehavioral health training series, as you see here on this slide. There's also a UW pain and opioid provider consultation hotline, which really is for these complex and high opioid use, complex management and pain. You see the 800 number here. There's also a CME accredited case conference series, UW Telepain, on Wednesdays. And then UW Psychiatry grand rounds and the archive there as well. Really wonderful too. So reminders, if you have a question or you're bringing a case forward, we respect PHI. So no displaying anything that could reveal any patient or family information. All sessions are recorded and available on our website. And please do complete the 1-minute post-session survey if you can. This is for you all, for our community, and we really want and do want to hear your input and feedback and how we can make this of greater value to you all. So this is, as we said, accredited through University of Washington School of Medicine, CME for one CME, actually 1.2 credits for our 75 minutes. Disclosures, nobody has any financial relationships that need to be mitigated. There are no financial relationships to disclose today. None of the planners, none of the speakers, nobody. And in the event that there ever is, all of those relevant financial relationships are mitigated. However, as I said today, there are none to disclose. This is our hub team, including our presenter today, Dr. Brock Gaster, and others, which are represented throughout a number of institutions, as you see here, and the Dementia Action Collaborative as well. We've provided almost 1,500 instructional hours since the inception during COVID, June 2020, and around 70% of our survey respondents say that they report back that they would make a practice change. They would implement a practice change based on the learnings. We have almost 90 sites, over 224 providers, and we want to continue to grow. So please, if you find this of value, do share with your colleagues. So it is with immense pleasure today that I introduce Dr. Brock Gaster, who is a professor of medicine and a developer of cognition and primary care, as well as Dr. Jacqueline Rates, who is a family medicine physician and a teacher in the residency program, as well as trained in palliative care and geriatrics. And they are both going to speak to us today together. I'm curious to see how that on cognition in primary care. So we're so fortunate to have you guys, and thank you so much for taking the time to share this with us.
Absolutely. Thank you so much for having us. And so it is such a pleasure to tell you about the incredibly work that Jackie Rates and I have been doing together with the team that you see here over the past 4 years, which is creating and building and developing the Cognition Primary Care program. And this is a really exciting time to tell you all about it, because we really are at this pivotal moment where we have really successfully completed a rollout to the 14 clinics that make up the UW Medicine Primary Care Network. And we're now in the process of packaging it and making it easy to disseminate to other clinics, other health systems. And so this is just an exciting time to tell you about what we've accomplished and where we're headed. And so without further ado, let me go ahead and just kind of frame that, what is cognition in primary care? Cognition in primary care is really a easy lift quality improvement initiative that's by primary care for primary care, to create a practical, efficient model to sort of answer the question, is my patient maybe developing dementia? How to make a diagnosis of mild cognitive impairment or dementia in the primary care setting, and really provide the tools for primary care to help to improve care and make brain health more of a solid thing that we can make a difference with. And so, as Nancy said, neither Jackie or I have any financial conflicts of interest to disclose. And the grant funding that we have had over the past 4 years has been mainly twofold. So we got a relatively large grant from a organization called the Davos Alzheimer's Collaborative, which is a 501c3 that collects money and then gives money to really improve especially the detection of Alzheimer's disease and related dementias. And then we've also gotten 2 different grants from the CDC that is really all about taking the GSA, Gerontological Society of America's KAER toolkit, and implementing it in a large health system, which is what we did, and which is what we're going to be telling you about. And so it's so important to really sort of ground this into what we really think of as the sort of sentinel moment that happens in primary care, that we really can make a difference of. And a lot of it is often grounded in the Medicare annual wellness visit, where very often a patient who may be 82 years old is there for their annual wellness visit, and they're generally really pretty healthy, but they sort of mark on the Medicare annual wellness visit questionnaire, or just happen to mention that they are worried about their memory. And I can tell you that 7 or 8 years ago, when I was first sort of focusing on becoming an expert on dementia in the primary care setting, it was this specific moment that I really felt totally inadequate on. Like, I really wasn't sure what to do when a situation like this comes up. And this is really like the sort of the moment to really think about, how can we help primary care do a better job when a concern like this comes up. And this could be like a patient or family bringing up the concern, like I just mentioned. It could be that a clinic is implementing something like a 3-minute screener, like the mini cog for everyone who comes in for their medical annual wellness visit, and that screen is positive. So that's kind of like a big concern that requires more evaluation. It could just be that the primary care provider is like, this person who I've known for years, they never used to come at the wrong time for their appointment. Or even somebody at your front desk might notice that somebody is coming in for the wrong time of their appointment, or just like not following the careful plan that you laid out in somebody who used to be like really, really on top of it. So that the PCP or anybody in the clinic staff could become concerned. So all of these concerns all sort of like raise the flag of like, gee, there could be something serious going on here, that all really lead to the need for an evaluation. And so the core part of cognition primary care is how to do that evaluation. So how to sort of funnel in all these people who a flag has been raised to what is the next step, what if. And so much, what often will happen is like, oh, I'll just send that person to a specialist. But we all know that the access for specialty care to even do this like first stage evaluation is just like really, really, really hard to come by. And that really, that's like specialists don't have the capacity or the access to do these first step evaluations. It's what health systems want too. They want the efficiency of primary care on the front lines to be able to do these evaluations. And it's really what patients want. Patients want, they don't want to be immediately like shipped off to a place that they've never been to before. They really want the trust and convenience of what is hopefully a relationship they have built with a primary care clinic, to have the evaluation done there at the clinic that they are used to getting. And that evaluation can sort of lead to better care. And so again, as I mentioned, the Cognition Primary Care program is really built on the KAER toolkit that was developed by the Gerontologic Society of America. K stands for Kickstart, A for Assess, E for Evaluate, and R for Refer, which is a pretty huge, giant, I mean, they call it a toolkit, but it's really almost like an entire hardware store, where you can sort of a primary care system can pick and choose from the tools that they provide and put together a system to implement. And so what we did is we took that very, very big toolkit and we really sort of distilled it down into a practical and efficient model, which is what we implemented at the University of Washington, that really is like designed to be really streamlined, really efficient, and accurate to give guidance on when a referral might be urgent, and really, with a big sort of reason is to really try to make sure that the referrals that primary care does send are really higher quality referrals. So fewer referrals for people who are just worried, well, who might have a perfectly normal MoCA and don't have any red flags from an observer. That person doesn't necessarily need to see a specialist. And so giving primary care the confidence and knowledge and skill of how to create better referrals to specialty care is really a big part of what the Cognition Primary Care program is all about. And so back to the case. So, what should we be doing when somebody comes in and says, I am worried about my memory? On one hand, you might sort of be tempted to reassure her and say, oh, don't worry, it's so common and normal to get forgetful with age. But you don't want to do that because there's a significant chance that person might have early stage Alzheimer's disease. You might be tempted to, again, automatically just refer everybody like that to a specialist, but as we all know, that is completely impractical and just like not the way the world is currently set up. You might want to drop everything and try to do a cognitive assessment right then and there, and then just blow up your whole clinic session and run really, really late. And that's just like a terrible sort of idea, because not only will you'll drive yourself crazy and your clinic crazy, but you'll also just not necessarily do a good job of that cognitive assessment if you're trying to squeeze it into that annual wellness visit. And so what you really want to be able to do is schedule an efficient follow-up visit with the primary care provider to evaluate this further. And that's really kind of like one of the big sort of light bulb sort of take-home messages of Cognition Primary Care that's not necessarily immediately obvious to primary care. Is like, oh, I could schedule a separate dedicated visit to just do a cognitive evaluation. And that's really sort of what we recommend as the best workflow. And to just create an acceptable, efficient, and accurate way to do that evaluation. And the three key principles of the Cognition Primary Care program are, we just like heard over and over again, this has got to be absolutely sort of bare bones and efficient. Primary care is so busy. There are so many things that we're constantly juggling. Really just make sure that this is really, really sort of slimmed down to the things that we absolutely need to make sure are happening at these visits. Really importantly, we provide tools for the primary care clinic, that this is not just CME. I think that there is pretty good data to say that if all you do is give somebody CME, that maybe they'll change what they do somewhat. They'll scribble down the notes as much as they can and try to remember the things that they learned and try to sort of implement that into their workflow. But really, if you also provide actual tools that they can use in their practice setting that are featured in the continuing education, that is the way to really do effective quality improvement. And so it's the tool support added to the continuing education is really the power, I think, of cognition primary care, really as a means to sort of get better care and really give primary care the easy actions of things that they can do to maintain and improve brain health, to really kind of overcome that kind of nihilism, that benign nihilism of like, oh, like, why should we open this sort of Pandora's box and have this complicated and psychological conversation about this disease if there's nothing that I can do? But like, no, primary care, there are things that you can do. And here's the checklist of brain health actions that you can take right now to really improve people's brain health. And so, and so much of it is just about sort of doing what primary care does best, which is patient-centered care, continuity, longitudinal care, following something over time, because maybe their evaluation is going to be okay, but that doesn't necessarily mean that they're going to be okay next year. And maybe things are so mild that they are difficult to detect right now, but this might be an evaluation that you're going to want to repeat in a year. And it's that kind of longitudinal ongoing care that's really what primary care does best, managing chronic disease. And just like thinking about dementia and as mild cognitive impairment as well, really is and should be a primary care disease in the same ballpark as diabetes. And so that's what the Cognition Primary Care is. It's a high quality continuing education series, 30-minute sessions that Jackie and I have gotten really, really good at giving, which is paired with EPIC tools to put that training into practice, or really any EHR that a clinic is using. These tools are so simple and concise that really these are text-based checklist tools that really any electronic health record can easily implement. And we want to share the data that we've collected over the past 2 years, rolling this out to the 14 clinics at the University of Washington Primary Care Network, and to show you that this is really something that is ready to disseminate now to other health systems. And so, I think really it's important to think of the Cognition Primary Care Program as an integrated whole that has 3 integrated pieces. So there's both the training, which is the continuing education, but they are really paired with both EHR tools that are simple checklists together with a clinic box kit that we mail to a clinic manager, and we open it with them in a 15-minute virtual visit to really make sure that the tools that we feature in our training are there and available to the primary care providers as they're seeing patients. And so these 3 components are really integrated with one another and really make this more than just CME, but actually it's sort of a quality improvement initiative that has some the tools that people can use. So just to say a little bit more about what our 3-part education series is. So it's 3 30-minute sessions. The first session is how to evaluate cognition in the primary care setting. The second session is how to set a plan for a newly diagnosed patient. And then the third part is tips for managing dementia as it progresses. We have been giving these as live webinars, but we are soon going to have them available as recorded video that people can stream on their own time. I think one of the main take-home lessons learned for us over the last 2 years is that as much as you try to schedule many webinars at many different times, there are going to be people who miss one session or are late to one session, or none of those times work for them. And we hear all the time, gee, can't we just watch a recording? And so that's really what we are moving towards, which is probably to offer both a webinar, live webinar option, but also to offer recorded video that people can watch. And then, Jackie Rates has also taken the lead on really developing an e-learning module that people can watch also on their own time, which is, rather than a recording of us giving a presentation, is actually just a self-directed clicking through our slides in a more fleshed out way than the slides alone. And so when we've given this training to primary care has just loved it. And I think one of the main reasons that it really does resonate with primary care is that Dr. Rates and I are both practicing primary care providers. And I think, given the fact that we are sort of still doing, 30 to 50% of our time is actually doing sort of full spectrum primary care in the primary care setting, we're able to talk to other primary care providers in a way that really makes sense to them, that they are like, wow, you guys really sort of get how hard it is to be in primary care, and what you're providing to us really is practical and efficient. And even when we survey them 6 months later, people still report increased confidence assessing cognitive concerns. And just saying things that like are really, really sort of meaningful to us in terms of we're on the right track, and we really sort of feel like we have a good approach that really does make sense to people, and is something that they feel like they can really use. And so just to talk a little bit about these three parts of the series, we're definitely not going to give you the 30-minute sessions, but just to give you the really sort of a high level outline of what these three parts are about. So the first part, again, is about evaluating cognition in primary care, in which we provide a really structured way to do a cognitive evaluation visit. And the way that we present the three parts of that cognitive evaluation visit are a cognitive checklist that we embed in the EHR so that people can remember what are the reversible causes, factors that they can make a difference in, how to assess cognitive function, where we generally recommend doing a MoCA test, and then really, really important to try so hard to get input from an observer. So either a family member or a close friend. And so I think the other sort of big aha hook for primary care is not only can you and should you be scheduling a separate dedicated visit to do a cognitive evaluation visit, or to do a cognitive evaluation, but try so hard to get either a family member or a close friend to come to that visit, because even the world's best dementia expert has trouble really sort of fully adequately assessing somebody's cognition without getting some input from an observer, a family member or close friend. And for that, we recommend using a structured questionnaire called the AD8 questionnaire, that is not necessarily a scored sort of instrument like the MoCA, as much as it is really a structured framework to take an interview, to take a history from the family member or close friend, that you can really sort of make sure that you're really getting a sense of how is that person navigating through the world. And so here's just a quick look at what the cognition checklist looks like. It's the simple labs that people generally remember to do, but it's nice to have that reminder. And remembering to look at their medication list, especially focusing on over-the-counter anticholinergics that may not be on their medication list, but that really may be affecting their cognition. Remembering to ask about alcohol intake, remembering to ask about other comorbidities that, if they're untreated or undertreated, really could be affecting cognition, like sleep apnea and hearing. And here's the MoCA that we really have still landed on as the best validated tool for identifying especially mild cognitive impairment in the primary care setting. And then here's just a snapshot of what the top part of the AD8 validated tool looks like for eliciting information from the family member or close friend. And again, it's paired with this really, really simple text-based checklist for the electronic health record to remind primary care that these are the main things that you want to be doing at this cognitive evaluation visit. And here's just a quick snapshot of what this starter box kit looks like that we mail to a clinic manager that contains the concise set of exam room tools that we can open at a virtual meeting with the clinic manager to make sure that the tools that we cover in the training are available in the primary care clinic for the PCP to put the training into practice. All right, and so now I'm going to pass things over to my colleague Jackie Rates, who will tell you about the next part of the video series.
Yeah. So the next session in our training series is to help primary care doctors start to set a plan and talk about the diagnosis for a newly diagnosed patient. So next slide. So let's go back to the case we talked about before. You had a patient, you've done a workup, and at the end of the visit, you feel that she clearly has mild cognitive impairment. The husband had reported she was repeating questions, but she's still fully independent with her activities of daily living. So at the end of that visit, you said, this is a lot to take in. Let's schedule another follow-up visit to talk more about what this means. So now 3 weeks later, they have returned and they're nervous. They're wondering, what's going on and what can I expect in the future? And so we really try to promote best practices in sharing bad news and also in navigating some of the stressful uncertainty that you encounter in medical care. So first, setting the stage, getting permission to share the diagnosis and talk about what's going on. You want to both acknowledge the fear around these diagnoses, but also be sharing optimism, emphasizing that it's good that we can know these things and be more prepared for whatever happens in the future. And make it clear that as a primary care provider, you'll be providing ongoing support. You're going to walk this journey with the patient and their family. We use a lot of tips from evidence-based, discussing serious news literature. Additionally, in part 2, we talk a little bit about what primary care providers should know about the newest anti-amyloid drugs, because it's important in terms of referral and counseling patients. Patients are seeing these advertised, they're asking about them. And then even if there's uncertainty in a diagnosis or not uncertainty in a diagnosis, no matter what, as you want the primary care provider to continue to promote interventions that are going to maximize and optimize brain health. So we've also created a post-diagnosis checklist that can help the primary care provider in follow-up visits continue to do things like recommend avoiding alcohol, avoiding sedating and anticholinergic medications, continue to treat contributing conditions, but also promote brain health activities like exercise and socialization, as well as start to give providers some information around resources. Throughout primary care and all different healthcare systems, there's not enough social work support. We are lucky at UW-Medicine that we have some, but many of our social work providers in primary care are engaged in BHIP, which includes counseling for things like anxiety and depression, and there's not a lot of bandwidth. And so we feel our healthcare providers should know a little bit about resources, which I'll talk about in a moment. Next slide. And we feel like this program really can complement something like the dementia guide model. Many of you have heard of the guide model, but for those of you who haven't, I'll just kind of briefly describe what it is. So it's a new Medicare pilot. It is a bundled payments for a healthcare system to provide wraparound services for a patient who has a dementia diagnosis. And there's a lot of healthcare systems who are applying for this and starting to roll out the guide model. And we see this as our Cognition and primary care program as really complementing the guide model because it's raising awareness amongst primary care teams and helping to make more diagnoses. Next slide. And finally, in our third part of the series, we talk about some tips for managing dementia. Some of the highlights include resources. Like I mentioned, it's important that providers can have a few resources at their fingertips. I think the Alzheimer's Association is a really easy one for providers to remember. There's a 24-hour hotline that's staffed by social workers. They can give both urgent advice, but also recommend local resources. All the programs offered by the Alzheimer's Association are free, and they also have translators in many, many languages. It's also become clear that most primary care providers don't know what area agencies on aging are. Every county in the United States has an area agency on aging, which is a clearinghouse of resources for providers, patients, and caregivers. And so we want to make sure that people who are both in our system, but also outside of our system, are able to locate their area agency on aging and refer patients and caregivers to that. We're a big fan of a caregiver program called Powerful Tools for Caregivers. In some cities, they offer in-person, but there's also online classes since the start of the pandemic. These classes are free and they are evidence-based. Caregivers who go through this program demonstrate increased self-care behaviors. They demonstrate increased confidence and coping skills and increased use of community resources. So I'm going to shift gears here to talk about the outcomes of our Cognition Primary Care program as we rolled it out here at UW-Medicine. We reviewed the electronic health record, looking at the use of the tools we created in Epic. We also measured cognitive evaluations done and looked at the number of MoCA tests that were entered into Epic. And we measured new diagnoses of early stage cognitive impairment. Additionally, for our training webinars, we did before and after surveys of a validated tool to assess knowledge and attitudes, as well as confidence in providing care. And like Brock mentioned, we rolled this out at 14 clinics within UW-Medicine. We've trained more than 125 primary care providers. And we chose the non-academic clinics. So these were all community-based primary care providers who spend less than 5% of their time in teaching or doing other research. And of these, within UW-Medicine, patients self-identify 41% from diverse backgrounds are non-white. Our training program, we measured statistical significance in improving attitude to care, engagement, and clinical confidence. And it's been shown that these items actually are what is needed to make change within clinical care. And I think Brock already went over some of the awesome comments that we got as well. Overall, it was very well received. We saw throughout the rollout of this program, steady increase in the smart tool usage within the clinics. And excitingly, we saw a ever-increasing number of Montreal cognitive assessments entered into the flow sheets of the electronic health record, which is Epic for us. These vertical lines kind of show the start and end of the intervention. Likewise, excitingly, we saw an increase in the number of patients within primary care who received a new diagnosis of mild cognitive impairment. So we're optimistic that this program can increase diagnosis of mild cognitive impairment. And turn things back over to Barak.
Yeah, so like I said, we're sort of at this sort of exciting point where we have rolled this out. We've done kind of a continuous quality improvement approach where as we've gone, we did waves of reaching out to the 14 clinics at the UW Medicine system, and each time sort of got a little bit better. And I think the training, the 3 training sessions that Jackie and I have given, we have given it so many times, and every time we're sort of constantly sort of tweaking the slides and making them a little bit better, that we now have a really, really high quality slide deck for these 3 sessions that we are in the process of recording so that they can be viewed on demand. And we really want to take this whole package though and make it easy to disseminate in dozens of health systems around the country. We're really going to especially focus on federally qualified health centers as maybe the places that are in some ways sort of struggling the most, but in ways that are like really, really engaged of like, we really, really want to do better with this problem. And like Jackie mentioned, really focusing on places that are especially have applied for and gotten approval to use this pilot CMS Medicare new model for dementia care called the guide model, where I think those places are going to be especially interested and keen to collaborate with cognition primary care, because I think there is really, really strong synergy between cognition primary care and a place that is implementing guide, because the guide model really requires an engaged and knowledgeable primary care workforce to make the diagnosis and then provide the collaborative care that the guide model really needs in terms of because the guide model is not like we just like kind of will take over care for that patient, but really we will take over this part of the care of the patient, and they really do need to work collaboratively with primary care. And so a primary care provider that has gone through the cognition primary care training is going to be a much better partner for the guide team. And so again, this is like kind of where we're at with this package dissemination. We are going to have recorded CME that are high quality videos, as well as a live webinar option, because I think even though not everybody is going to be able to attend that live webinar, to some degree, I think having that opportunity for some live Q&A at the end of the webinar is sort of good and exciting for people. And as I mentioned, we also have an e-learning module where people can sort of work through most of the content that's in the slide deck without actually listening to a recording of the presentation, but can sort of go through it as a self-directed learning experience. We are putting together an implementation guide for the electronic health record that is sort of agnostic to what electronic health record a system might be using. More and more people are adopting Epic, but these tools are so simple as really text-based checklists that it's an easy lift to implement them into any EHR, and we provide a guide for making it really easy for them to do that. And I think the other really big important change that most EHRs still need is to create a field to enter in a MoCA score or whatever cognitive test they may be using. That right now, the current state is that just about every EHR system is requiring or relying on people just entering these as free text into their note, and they're scanning the MoCA sheet that the person drew the clock on. But it's still hard to find that result. If it's a scanned document that's in hundreds of other scanned documents, or it's free text that's buried in somebody's note, it's not the kind of discrete test result that you really want to be able to quickly find and quickly track over time. And so creating a place in the electronic health record that is really analogous to like the PHQ-9 that has really become very standard for assessing and managing depression. So the PHQ-9 is a discrete score that has a discrete result field in the EHR. It's really usually putting right next to that a place to enter a MoCA score, so that MoCA score can be easily found and tracked. And like I mentioned, the starter box kit is really a box that we mail to clinic. We open it at a virtual meeting with a clinic manager to help them put the folders into place to make it easy to put the CME training into practice. And so we're really sort of, ready to launch this out now to beyond the UW medicine system, really wanting it to be scalable, which is, I think the recorded trainings are a big part of that, so that we really could theoretically reach thousands of PCPs. We're about to start a program, a collaboration with the AAFP, the American Association of Family Physicians, to bring cognition and primary care to their members across the country. We're really wanting to build, especially the continuing education series, as something that is really built in a modular way that will allow us to quickly update different parts of those videos as care advances. We really want this to be sustainable as well. So we're really thinking about what might be low-cost strategies to facilitate rapid uptake of cognition in primary care in many, many systems, with the big hook that cognition primary care doesn't require a system to hire new staff. You're not creating a new role, you're not building a new service line. This is really sort of plug and play to give primary care the tools that they need to sort of take what they are already trying to do, what they already do best, and just allow them to do it. And so that is the Cognition Primary Care Program. Really, it is such a pleasure to be able to present it all to you today, and glad to see that we have plenty of time for questions. And so let me stop sharing. You feel free to go to our website, cognitionprimarycare.org. We are hoping that in the next 3 to 6 months, we're going to go through a really sort of important redesign of that website to really change its focus from being what has been a somewhat focus on the UW medicine system to making it more kind of outward facing to other health systems. We've already started to do that some, and so like what you'll see on Cognition Primary Care is still a little bit sort of focused on UW medicine, but we have started to make it more outward focused as well. But I think we really do have exciting work to do to redesign that website in the next 3 to 6 months. And we do think that it's going to be on this website that the recordings of our continuing education sessions will be available for free, and probably for continuing education credit. And we also are going to really try to gather some data about the people who are taking the training to give them the before and after survey, and also try to gather a little bit of demographic information about them so that we really can track who has been taking our training, and maybe reach out to some of them to see if they would be interested in having the full quality improvement initiative brought to their clinic.
Wow. Thank you, Barack and Jackie, for such a fantastic presentation of cognition and primary care, and for the wonderful work that you're doing to improve the tools and the training and the confidence and the engagement. And I know we can send out the paper that you referenced as well to our community. So there's a couple of comments in the chat. Karen Hayes is thanking you for describing the program for primary care providers. Caregivers, especially from rural areas or without resource, time, good insurance, often feel guilty or remiss when their person hasn't gone to a neurologist for assessment and management. And then, just conveying primary care providers can do so much for the majority of patients' families coping with cognitive impairment. Thank you for that comment, Karen. Anybody else with comments or questions that they would like to share? And please, if so, if you can unmute yourself and put yourself on video, or feel free also to post in the chat, whatever works.
And while people are thinking of questions, I can sort of just add on that I think that one of the biggest challenges that we still face is like what's with the MoCA? Like is the MoCA really like the best sort of test that we should be doing? And I really do hope that in the coming years that a better test than the MoCA will emerge, and that ideally it really should be like a digital cognitive tool that has more automated scoring to it, so that there isn't, I think like right now there still can be a little bit of like a question mark of how many points should I give somebody for this clock, and how exactly should I be scoring it. And so I think that having a digital versions of tests is going to be really where we should be going There's also a lot of clinics that are already using a different cognitive test like the RUDOS, which we really do think is a really important sort of option, especially for patients who have really low literacy, and so not even just like a language barrier, but if they've never really been to any kind of structured schooling, then some of the features of the MoCA test are going to be less accurate. And the RUDOS, which is a cognitive test that was developed in Australia, it does have good validation for using in a population like that. And but I really do hope that 5 years from now that we have something that is better than the MoCA, and but it's still, I would say, the best thing that we have for now.
Thank you.
And there's a good question in the chat
JD,
here.
do you want to unmute yourself and ask that question? If you can.
I was just wondering how the slums compares to the MoCA. Is the MoCA more accurate?
What I would say is that the MoCA has been much better validated. The number of studies out there that show the accuracy of the slums compared to what is out there for showing the accuracy of the MoCA is really pretty tiny. The slums, the SL in slum stands for St. Louis. It was developed at the St. Louis VA. So almost all the validation that has been done of the slums has been in male vets in St. Louis. And so it's a relatively sort of like it has some features that I think are sort of culturally odd and not necessarily. I would be very interested to see what kind of data would be found if you really did sort of put the slums to the same kind of validity testing that the MoCA has done. So I mean, I would say, given a choice between slums or MoCA, I would definitely recommend MoCA over slums. There are some people who get a little bit scared off by the MoCA because the MoCA website has like very alarming legal sounding language that it is mandatory that you take our sort of training in order to give somebody a MoCA test. I can tell you that the conversations that I have had with legal counsel for UW Medicine, and that I have also heard from many other systems where they have run it by their legal counsel, that if you really read the fine print on what's on the MoCA website of this requirement to take their training, it is much more designed to protect the makers of the MoCA test from being sued, rather than there's really any intent for them to sort of try to enforce any rulemaking that they're making about this. It's not, they're not making a copyright claim. It really is perfectly okay for anybody who has a copy of the MoCA to give the MoCA without doing that training. It's not that that training is necessarily bad. I mean, they charge like $100 for it, and it takes something like 30 minutes or an hour. And so I think, especially if you're in a health setting where you're going to try to have, say, medical assistants give a MoCA, then having them go through that training is probably sort of like a good, reasonable thing to do. But I think most primary care providers can do a good job doing the MoCA without doing that training. And I would certainly not be concerned. I'm not a lawyer, so I can't give you legal advice. But I can say that my understanding is that using the MoCA test, even without taking their training, is a very, very low risk thing to do. That most health systems, if they really do read the fine print of what's on the MoCA website, will agree, oh, this isn't that big of a legal claim.
And I'd add that being said, any validated test is better than doing no validated test. So often in primary care, we get paralyzed by competing demands and not enough time. And so if your system has like a way is using slums and everyone's familiar with it and it's right there and people can help you do it, it's so much better than not doing anything. Looks like there's one more comment in the chat.
Yeah, Lucia, do you want to unmute yourself and share your comment?
Hi, I just wanted to say thank you. Just thanks so much for reinforcing that, you know, it's okay to take that space to make just to really get into that concern a lot more. I feel like primary care, there's so much pressure to just do as much as we can for every single visit. But I mean, there's also continuity, and sometimes we just need to chip away at it over time. Thank you.
Agreed. Sometimes it takes even longer than one visit. Sometimes things are just so slow that you have to do it over several visits.
Great. And Janine.
Thank you. I just wanted to ask about the MACE, because our organization went from MOCA to MACE a few months ago, and it's done by the OT. We used to have our social workers do MOCAs yearly, or providers do them. Now we don't do them. So I wonder your opinion on that. It's very different.
Yeah, I mean, we are so agnostic really to kind of like which test somebody does, you know, like Jackie said, you know, doing a test is better than doing no test. And I don't think that there is, you know, there are many tests out there, and especially when you start thinking about digital tools, you know, there are, you know, 8 or more companies that are developing digital cognitive assessment tools that are, you know, based on, you know, the MOCA. I mean, all of these tests are really, you know, trying to take the neuropsychology science and put together combinations of different combinations of tests that test different domains. And so I don't think that, you know, one is the be all and end all. And like I say, like there are parts of there are aspects of the MOCA that I just like hate, and like I really am eager for there to be something that better that comes along.
And Reza, you have your hand up?
Yes. Hi.
Hi.
You know, you shouldn't forget that these are first. Hi, Nancy. My long time no see. So we shouldn't forget that these are just screening tests. They are not diagnostic. And if you can, and even for MOCA, you can see that less than 26 is abnormal, and that's it. And then you can figure out that based on the these 2 more tests, clinical evaluation, MRI, PET scan. Those are our tools, basically. It's a combination of them. You can do the MOCA test for a patient. I had a few patients, and they got, for example, 24. Next time they came back in the morning, early morning, with a good sleeping, with a good breakfast, they got 28. So these are, I don't see huge differences between them, honestly. I mean, if I don't have MOCA, yes, I do the slums, basically. So all of them just screening tools for us. Further evaluation needed. And I mean, at that time, I think you can just order MRI, look at the hippocampus size, do the PET scan, and all of those tests. I'm not a fan of technology for screening tests. Why? Because my 8 years old patient cannot navigate easily through the computer system. It takes time. If Barak and I, we reach that age of the 78 years old, we want to do the memory test for ourselves, maybe we can do that. But for this generation, absolutely MOCA, slums, all of those, I think they are preferred. And we did basically an evaluation of those computers in our clinic. It was not successful. I talked to many neurologists about them. Still, MOCA or doing something on paper is much easier for this generation of older patients, until we reach the generation of the computer savvy people who can take care of that. So that was my point, and thank you so much. That was great to bring the memory care to primary care. One more thing, one of the most important parts of this memory program is social worker. I said many times to my colleagues that I'm paralyzed without my social worker. I prefer not to do memory evaluation without having them. I think it's necessary to emphasize and ask the social worker in primary care to be involved in this type of care. And, you know, I used to teach residents from Virginia Mason until last year. And over the 10 years, I told them that if you don't want to do MoCA, that's fine. Just do Minicoc. Start with something simple, then go ahead and do something different. One more thing. MoCA and many mental status tests, they are copyrighted. STOMP is not.
Mhm.
Yeah, so MoCA has an unrestricted copyright though. So they you know, they don't want anybody to kind of like be charging for it without their permission, but you do not need the legal language on their website does not say that you need their permission to use the MoCA test. And so it's very, very different than the mini mental status exam. The mini mental status exam has a copyright that they enforce where you are really supposed to pay them, you know, it's like $2 or something every time you give somebody a mini mental status exam. But that's like a very, very different legal claim than MoCA has with their copyright. And, you know, I'm so glad that you sort of brought up the word screening because, you know, that's obviously everybody is a little bit on sort of pins and needles because the United States Preventive Services Task Force is in a process of sort of updating their recommendation for cognitive screening. And people are wondering of like, gee, are these new FDA approved drugs going to change the United States Preventive Services Task Force recommendation about screening? And so we'll all sort of be waiting to see what happens with that over the next year. But in terms of like using the word screening for the MoCA, it's important to differentiate between a very, very brief test like the Minicog, which is like a 3-minute test, which I do think of as very much a screener. Like, you know, nobody can really, anybody who has an abnormal Minicog absolutely needs to have more cognitive function testing done. And it's also a little bit tricky because lots of people can do perfectly okay on the Minicog, but still have mild cognitive impairment. It has a pretty low sensitivity for identifying mild cognitive impairment in the primary care setting. But so whereas I would think of the MoCA test as more than a screener. And so like you're absolutely right that you're not going to just stop with the MoCA test, but I would think of the MoCA test as useful as a diagnostic tool that you put together with, you know, an assessment of somebody's sort of clinical situation, together with getting input from an observer, and together with, you know, maybe sort of imaging of the brain. And like that, though, that is like the diagnostic tool set that you're going to make a diagnosis. And so I really want to emphasize that the MoCA is part of that tool as a tool set as a diagnostic tool rather than as a screener.
Thanks.
In our clinic, we can ask you, for example, your MA, do the Minicoc test. In our clinic, at the first visit, geriatrics clinic, we do MoCA for everybody, basically, even if they want or they don't want. MoCA is a part of the first evaluation. But for busy family practice clinics or internal medicine clinics, I think the best way would be just asking your MA do the Minicoc test. And if it's abnormal and you see some change, some signs in your visit, then you go ahead to do the MoCA test. Thank you so much. That was a great
Thank you, Reza. Thank you so much. And we will put in our follow-up email a link to a talk that Dr. Carolyn Parse gave about comparing across some of these detection and screening tools. Marissa, do you want to unmute yourself and add anything to your comment? And then Sylvia.
Sylvia had her hand up for a while there. Sylvia, did you have a question?
So my very brief question is, I'm supposed to give a lecture to the primary care physicians here for the Spokane Medical Society, Internal Medicine Society. Is it okay to share that CDC training and information with them?
Yes.
Perfect.
Definitely.
Yeah, it was put up for free by CDC because they want it disseminated.
Perfect. So I'll share your website and that link. So hopefully we can help them a little bit better.
Great.
Thank you, Sylvia. That's great. Go on, Jackie. Sorry.
I didn't say anything.
Oh, sorry, it was
Oh.
Marissa.
Oh, Marissa. Okay. Yeah. Okay.
So just like from experience, we used a digital screener for a little while in the geriatric care clinic, and it was really hard for the folks with any, I don't know, peripheral neuropathy, more severe cognitive impairment, lack of technology, familiarity with an iPad or a computer to use it. I think that's going to change over time. So I think it is wise for, thinking about the next generation. What is this going to look like 5 or 10 years from now as people age and they're already tech savvy and it's kind of ingrained into their memory and such. So that's one point that I wanted to make. And then just about like the MoCA as a screening test versus a diagnostic test, I think there's so much information that can get pulled from a MoCA. But I do think like based on how the person's doing that day can really matter. And so I do sort of think about it as a screening test, but only because I've worked in the practice setting with the privilege of neuropsychologists and that referral system, because they do so much more. And so I think thinking about it as a diagnostic tool when that isn't a resource, but when there is the resource of neuropsychologists around, they're so wonderful and it's so important to use them. That was the point that I wanted to make.
Yeah, that's a great point.
Absolutely. I think that, the more testing, the more complex testing you can do, the more certain you can be in a diagnosis. And sometimes depending on a patient and family's goals, a degree of uncertainty is okay. They may not want further specialty care, and this is just sort of information. And so you're right, it's sort of like graded in terms of what's if you can get more detailed diagnostics, then that's great, but that's not always available to everybody all the time.
And I'm just like, I'm so glad you said that about neuropsychologists because, boy, oh boy, does the country need 100 times more neuropsychologists than it currently has. I think that, if everybody who has kind of a borderline MoCA, if all of them could get neuropsychological testing within the next sort of month or two, like, yes, that's absolutely what we need. And it's just like so vanishingly impossible for most health settings to have that. And which is why I really do think that we need something that's better than the MoCA, but like a lot sort of more kind of like high volume efficient than to our neuropsychological testing. And that's really what I see as the biggest challenge that this field faces.
Anybody have any questions or comments about the checklist, the utility and applicability of this really great checklist and kind of focusing on brain health as well? Primary and secondary prevention.
Hi, I'm Candace. I am a geriatric fellow at UW right now. I just want to say I just finished family medicine residency in Tri-Cities. So this is actually a really great tool that I wish we had before. It just creates a nice structure and easy to follow. At least like it really starts, give us a little bit more guideline than kind of like starting from nowhere. So I find it to be really extremely helpful. So thank you.
Thank you, Candace. Great. Karen, do you want to add anything? Karen Clay, to comment? As a social worker on the hub.
Yeah, I want to add, I think that, I do think that in terms of helping folks maybe dive in a little bit more about sort of for family members, how to help support their loved one. I do think that encouraging folks to get resources, get connected with that. And I agree that, you know, primary care and specialty care, social work is really really pretty sparse. But there is the Alzheimer's Association. They do have that 24-hour helpline that is staffed by social workers that can really do a lot of coaching, you know, sort of like in the moment when you're need some problem solving skills. That's a great use for that. I think it was Jackie mentioned the area agency on aging to sort of like who is their local dementia expert. Most of the local area agency on aging across the state do have somebody that really is honed in on what those dementia care strategy and trainings are. Yeah,
Great.
and I do think too, like we are sort of seeing increased possibilities for reimbursement for social work services. And I do hope that that is going to translate to having more social work availability in primary care clinics and specialty clinics as well. That could make a big difference. I know that's a big barrier for most clinics is the financial component of it.
Mm-hmm. And the uncompensated care provided. Yeah. Hang,
right.
please.
Good
Thanks.
job, Barack and Jackie. Thank you. Thank you. Can you explain more about the dementia guide model? You mentioned something about the clinics can apply. Or
Yeah.
did I?
Yeah, the guide model is in many ways, I think of as the most exciting thing that's happening on a national level in terms of dementia care. And it has its roots in local places like UCLA and the University of Indiana and Emory have like for years been building these really sort of very sort of discrete, multidisciplinary dementia care models, and but they've been mostly funded by philanthropy. And so there has been this big sort of many year process of getting CMS Medicare to think about, well, how would we actually pay for that, not by philanthropy, but through actually Medicare payment. And so they came out with this guide model, which is a pilot payment model that CMS Medicare has launched, which is really, it's like a value-based bundled payment. So there's a certain degree of kind of capitation where you get the health system, the clinic will get paid a certain amount of money for each patient enrolled, which is supposed to help them to pay for a very elaborate suite of services that are, you know, the things that like we all aspire our memory specialty clinics to have, which is, you know, respite care and social work care and just, you know, lots and lots of features. I mean, really, it is like it's a 24-page list of required services in order to qualify for this guide payment model. And so it's like launching with I think like 200 sites around the country applied and got approval to try it. And so it's going to be really interesting to see sort of what happens as all of those sites try to get their programs off the ground. You know, I think, but the key point that Jackie made is that these are care models that require patients to come in with a diagnosis. And so that it really is going to be challenging for those places to also solve the problem in their sort of location of how can we make sure that patients get the diagnosis and get into that good care.
Thank you. Is UW the guide model? I mean, do you?
No, we looked at it, we thought about it, we looked at the 30-page requirement for all the services required and decided that we sort of weren't quite ready to sort of be in the first wave of people trying that out.
There is trying a collaboration that's in this region in the Puget Sound that received a guide award, which is a combination of the Alzheimer's Association, which teamed up with Ripple to implement the guide model, as I say, in the Puget Sound. And then I think there was another award in this area. And then down in Southern Washington, Portland area, there's a Care Ecosystem Guide Award. If you're interested, you could go on their website, or we could put it in.
And it's important to emphasize that these are not awards, because they're definitely not getting any money. You know, what these sites are getting is the sort of the
Opportunity.
the opportunity,
Yes.
the permission. They're getting
Yes.
permission to build this program and then bill for it. And so whether, you know, I think it's unlikely that all 300 that sort of got approval are going to actually be able to kind of come through with everything that is required. But it's going to be, I mean, I think it's like absolutely promising, as, you know, what we really hope, you know, every patient with Alzheimer's disease and related disorders will have access to in, you know, 5 to 10 years from now.
Hey, thank you.
Thank you for clarifying too. All right, well, we have 2 minutes. Maybe I'll just, in the last 2 moments, share. Sorry, going back. Yes, please bring your cases forward, reach out to Sammy. As if you're from University of Washington, text 10085 to this number. And here are upcoming didactics on the 27th, Sexuality and Dementia with Dr. Douglas Lane, and so forth. And please do complete our last 1-minute post-session survey. And thank you all so much. If there are there any more questions? We just have 1-ish minute. And if not, then I will just again extend our greatest gratitude for that outstanding presentation on cognition and primary care. And thank you so much, Jackie and Barack, for the fantastic work and presentation. Thank you.
Bye.